In this video, we're going to cover the neurological exam, which is the primary tool that neurologists and other clinicians use to assess patients and come to an accurate diagnosis. Before we get started, I wanted to give a huge thank you to Dr. Paul Larson at the University of Nebraska and Dr. Suzanne Stenstas at the University of Utah for making a series of amazing videos on the neuro exam and allowing me to use them in this lecture. I would recommend that you bookmark this website for your own learning, as it has lots of good examples of both normal and abnormal findings on the neuro exam. The neuro exam is best thought of as a series of systematic tests that assess the function of all aspects of the nervous system across multiple areas of the body. This helps to localize dysfunction to specific parts of the nervous system, making it an invaluable tool for diagnosis. The neuro exam is a long and complicated process, and you'll need a few tools to perform it, including a reflex hammer, a tuning fork, vibrating prongs, and something both soft and sharp like a wooden cotton swab that can be snapped in half. In this video, we'll use a rhyming scheme that will allow you to remember each aspect of the neuro exam. This can be helpful to make sure you're not skipping any steps and to avoid looking unprepared in front of a patient or preceptor. Let's use the following rhyme to keep the steps of the neuro exam in mind. Head and hammer, feet like tots. Bulk and tone, pretend we fought. Stroking, poking, shaking hot. Touch my finger, stand and walk. Let's break these down one by one. The starting point for the neuro exam is to assess the patient's head or mental status, which includes their overall level of consciousness and cognitive abilities such as concentration and memory. Even within the first few seconds of the exam, you can often get a sense for whether the patient is fully alert or whether they are sedated, confused, or even comatose. However, if you'd like to assess this more systematically, you can ask the patient basic orientation questions, including who they are, where they are, around what time it is, and the purpose of their visit. Additional tests such as simple arithmetic and memory games can provide further clues. In cases where you suspect cognitive impairment, you may consider using a structured test like the Mini Mental State Exam, or MMSE, or the Montreal Cognitive Assessment, or MoCA, to provide a more detailed picture of the patient's cognitive abilities. After assessing their mental status, the second part of HEAD is to do a cranial nerve examination. Testing each of the cranial nerves can help to localize any deficits in the cerebrum or brainstem. Use the ooh to touch and feel very green vegetables mnemonic from a previous video to remember the order of the nerves. The olfactory nerve is difficult to assess unless if you specifically brought something with you or haven't bathed in a few days. Some neurologists will carry a small jar of tea leaves, coffee beans, or some other object with a distinct but not unpleasant odor to test that the patient's sense of smell is intact.
I just hold this substance up. Can you smell something? Mm-hmm. And can you identify what you're smelling?
Coffee.
That's correct. Okay.
The optic nerve can be assessed in a few ways. If you want to get an overall sense of the patient's vision, you can test visual acuity by asking the patient to read something at a fixed distance, like the Snellen chart used in this video.
And then we're going to use the pocket Snellen chart, and I want you to actually hold this in your own hand so it's comfortable at your length of focus for you. And read the smallest line. Which line can you read?
The smallest one.
Can you read the bottom one?
Yeah.
Okay, go ahead and just read the numbers.
428739.
That's correct. Very good.
If you need information about deficits in particular visual fields, like if you're trying to determine if a patient has hemianopsia or quadrantanopsia, you can test these using a technique known as confrontation, as in this video.
I'm going to hold up one finger or two fingers, one side or the other side, or just count the number of fingers I hold up, okay? And again, watch my nose, and through the side of your eyes, look and see if you can identify a number of fingers being held up.
1, 1 and 1.
Very good.
1.
Very good.
1 and 1.
Very good.
1, 1 and 1.
Very good.
The three cranial nerves controlling extraocular movements, the oculomotor, trochlear, and abducens nerves, can all be tested together by asking the patient to follow your finger with their eyes while keeping their head still. Move your finger in an H shape in front of the patient's head to confirm that their eyes are able to move fully in all directions.
Okay, watch it over here. Watch it up. Watch it come down. Watch it come over here, up and down, and back to the midline. Very good.
Finally, when you are done testing that the eyes can move in all directions, move your finger in towards the space between the patient's eyes. This is to test for accommodation, meaning that as the patient's eyes cross inwards, the pupil should constrict.
Keep watching it as it comes in. Stay focused on the tip of the Q-tip. Very good.
Finally, test for the pupillary light reflex by shining a light into one eye at a time to ensure that both of the patient's pupils constrict in response to this. This test relies on both an intact optic nerve to carry the signal back to the brain, as well as an intact oculomotor nerve to carry the motor signal back to the pupils.
And I want you to, again, just keep looking over there. We're going to look at the direct as well as the consensual. We're over here to the direct and consensual, both coming out equally. And now we're going to do the swinging flashlight test. We're going to go from one eye to the other eye, back and forth. Both pupils stay down. There's no evidence for a deafferented pupil or a sensory defect. So that's good. That's fine.
Moving on to the fifth cranial nerve, we need to test both the sensory and motor functions of this nerve. The sensory component of the trigeminal nerve can be tested by lightly drawing a soft object like a cotton swab across the forehead, cheek, and jaw on both the left and the right.
And we're going to test all three divisions of the trigeminal nerve. So first of all, can you feel that up here in your forehead?
Yes.
Over here?
Yes.
Does it feel about the same?
Yes.
So testing the maxillary division, the ophthalmic division. Testing here, same on both sides, the maxillary division. Same on both sides,
Yes.
mandibular division.
In contrast, the motor component can be tested by asking the patient to clench their jaw as well as try to open it against resistance.
Now open your mouth and don't let me push. And we're actually testing the pterygoids and there's no jaw deviation, so that's normal.
The facial nerve is another nerve that has both motor and sensory components that need to be tested separately. The motor function of the facial nerve can be tested by asking the patient to perform a variety of actions involving the muscles of their face, including raising their eyebrows, closing their eyes tightly, puffing out their cheeks, and showing their teeth. Look for weakness or asymmetry in any of these actions.
We're going to look at the cranial nerve number 7 and actually have you lift up your eyebrows, frontalis muscle, very good, and close your eyes really tight, like you have to open them. There's oculi muscles, very good. Don't let me open them, keep them tight. Good. Okay, open up your eyes. Now I want you to show me all your teeth. And look at the nasolabial folds, that's fine. And I want you to puff out your mouth like you're going to kiss or going to blow. Very good.
You can simultaneously test both the 5th and 7th cranial nerves using the corneal reflex, in which you try to gently poke the patient's eye with a soft object. The patient should quickly shut their eye to keep out the incoming object. This reflex relies on the ophthalmic branch of the trigeminal nerve for its afferent limb and the facial nerve for its efferent limb.
I'm just going to barely touch and just tell me if you feel it. Do you feel that?
Mm-hmm.
Okay, we get the blink as well. Look over here. Not all the way, just right about there. Good. Just going to very touch the limbus of the corner of the corneal. Did you feel that on both sides?
Yeah.
Okay. Very good.
Finally, for the sensory component of the facial nerve, you can soak a cotton swab in some sort of flavored liquid like vinegar and use that to test for taste sensation in various parts of the tongue.
Okay, so go ahead and stick your tongue out, all the way out. I'm just going to touch one side. Do you think you can identify the taste?
Mm-hmm.
And what is it?
Sugar.
That's correct. Let's do the other side. Have you stick out your tongue? Again, I'm going to just touch it to your tongue. And don't put it back in until you feel like you've been able to identify it. Or if you can, okay?
Salt.
That's correct.
There are a few ways to test the auditory component of the vestibulocochlear nerve. The easiest one is to simply rub your fingers together outside of each of the patient's ears and ask if they can hear the sound.
And we're going to first test auditory acuity. Do you hear that?
Mm-hmm.
And what is it that you hear?
Your fingers rubbing together.
Okay. How about over here?
Same.
Is there any difference between the two sides?
No.
Okay.
If more in-depth testing is required, you can use a tuning fork to perform the Weber and Rene tests.
We can further test that by doing the Weber-Rene test. The Weber test is actually using a tuning fork, placing it on the forehead. And do you hear that on one side or the other or the middle?
In the middle.
Good. And then the Rene, we're placing it back on the mastoid. Can you hear that?
Mm-hmm.
Can you tell me when you can no longer hear it?
Okay.
Can you hear it now?
Yes.
And we should do the same thing for the other side, but another way to screen with a Renee is to ask the patient which is loudest. Number 1 at the mastoid, or number 2 air conduction.
Number 2.
And that's the correct answer. That would be the normal response.
The vestibular component of the 8th cranial nerve can be tested by using the doll's head maneuver, which involves asking the patient to fix their eyes on a specific point in their vision and then moving their head around. If their eyes are able to stay focused, this means that their vestibular system is accurately assessing the position of the head in physical space.
Keep focused right there and don't move your eyes. Keep focused, and I'm going to turn your head quickly, but you keep looking over there. Go up and down. Very good.
The glossopharyngeal and vagus nerves can be tested together as they are both involved in uvula movement in the gag reflex. This is the classic say ah movement when you visit the doctor.
Tilt your head back a little bit and say ah.
Ah.
And watching the action of the palate, say ah again.
Ah.
And that's totally normal.
If there is any unilateral weakness of these muscles, the uvula will deviate away from the weakness, as the non-affected side is pulling on it stronger than the weak side. The 11th cranial nerve, the accessory nerve, can be quickly tested by asking the patient to shrug their shoulders as well as to turn their head from side to side against your resistance.
I want you to flex your shoulders up like this. Don't let me push them down. Good. And now I want you to turn your head to the left, and we're going to look at her right sternocleidomastoid muscle. Don't let me push your chin. Good. And I'll go over here to the right. And again, don't let me push. We're going to look at the left sternocleidomastoid muscle, and that's normal.
Finally, the 12th cranial nerve, the hypoglossal nerve, is easily tested by asking the patient to stick out their tongue.
Stick out your tongue all the way out. Comes out at the midline. I want you to go in and out, just back and forth. Good. And now side to side without moving. There you go. And then just close your mouth and put your tongue over in this cheek. Push it out hard. And now over on this side, push it out. Good.
Any weakness on one side will cause the tongue to deviate, although in contrast to the uvula, this will be towards the weakness rather than away from it. For example, in this video, the patient's tongue goes to his right, so it's the right hypoglossal nerve that's likely to be affected. You can remember this by thinking, you lick your wounds. Okay, after that long detour through the cranial nerves, let's get back to our neuroexam rhyme. The next word after head is hammer, which should remind you of a reflex hammer, the tool that is commonly used to test deep tendon reflexes. Testing reflexes assesses the functions of a few things: the sensory neurons in the area, the spinal cord at the level of the reflex, and the motor neurons traveling to the muscles. The prototype example of this is the patellar or knee-jerk reflex. When the patellar tendon is tapped, some of the sensory nerve fibers travel directly to the nerve roots of motor neurons in the spinal cord, causing an immediate kick of the leg. Decreased or absent reflexes, known as hyporeflexia or areflexia respectively, tend to suggest damage in the afferent or efferent nerves involved, while brisk or hyperactive reflexes, known as hyperreflexia, tend to suggest involvement of the central nervous system. The most commonly tested deep tendon reflexes are the biceps reflex, the triceps reflex, the patellar or knee jerk reflex, and the Achilles or ankle jerk reflex. These cover both limbs of the body, so they're helpful for localizing lesions in the spinal cord. For this reason, let's learn a few memory aids to remember the spinal nerves associated with each one. For the biceps and triceps, draw a stick figure but use the numbers 6 and 7 instead of arms. The 6 looks like someone flexing their bulging biceps, while the 7 looks like somebody showing off their triceps. For the patellar reflex, draw a stick figure using an L for the lower half of the body to show that he is kneeling on 2 legs or even down on L4s. This should help you remember that the knee-jerk reflex is between L2 and L4. Finally, for the ankle jerk or Achilles reflex, write Achilles like it is here, using Roman numerals 1 and 2 for the I and L's, as well as emphasizing the S at the end. This should help you link this to S1 and S2. Going back to the rhyme, feet like tots refers to a set of primitive reflexes which are so named because they're typically exhibited by infants but not adults. While the underlying reflex circuits are present for people of all ages, as someone gets past 1 or 2 years of age, the frontal lobe develops to the point where it's able to automatically inhibit these reflexes, which makes sense as it's the part of the body that says no. For this reason, reappearance of primitive reflexes in an adult is indicative of either frontal lobe pathology or of damaged upper motor neurons that would carry these inhibitory signals down to the body. By far the most commonly tested primitive reflex is the Babinski sign, also known as the plantar reflex. To perform this test, drag an instrument, such as the sharp end of a reflex hammer, on the bottom of the patient's foot on the lateral side from the heel to the toes. In healthy adults, this test will be negative, meaning that the toes will naturally curve in towards the stimulus. In contrast, a positive Babinski sign occurs if the toes instead fan out away from the stimulus. This is why testing of primitive reflexes is called feet-like tots. The toes react in the same way that an infant's would. You can remember this by thinking that the Babinski sign is only normal in babies. While the Babinski sign is the most commonly tested primitive reflex, a few others exist. This video shows the snout reflex. This reflex occurs when the lips reflectively pucker up when something is pressed onto them, a normal response in a baby, but less so for a grown adult. This reflex, and a few others like it, like the rooting, Moro, and palmar grasp reflex, are used clinically in a similar fashion to the Babinski sign. The line, bulk, and tone pretend we fought refers to the 3 steps of testing the motor system: observing the bulk or overall size of the various muscles, noting their tone, and testing their strength by pretending to fight against the strength of the patient. We'll go over each of these. Determining the bulk of muscles does not require any sort of sophisticated maneuver. Instead, you simply observe. Someone with focal wasting or atrophy of specific muscles may have sustained damage to the motor neurons innervating that muscle, as a lack of nerve supply tends to weaken muscles like a flower without water. Muscle tone can be assessed by asking the patient to completely relax while you perform various movements on their behalf. The tone of one's muscles can suggest different types of pathology. A weak or flaccid tone may suggest lower motor neuron damage, especially combined with wasting. In contrast, a spastic tone involves muscles that are unusually tight, stiff, or jerky. This usually indicates upper motor neuron damage. Finally, testing the strength of muscles can be done by asking the patient to resist you in performing various actions. For example, you can test the muscles of the arm by asking the patient to bend their elbows and try to extend their arms while you push against them. You can do this for various muscle groups throughout the body, so make sure to do it for at least a few in the upper extremities as well as the lower extremities. Muscle strength is traditionally graded on a scale between 0 and 5, with 5 being full strength resistance, 4 being some resistance, 3 being resistance against gravity but not against you as the examiner, 2 being some movement but no ability to hold up the limb against gravity, 1 being a flicker or twitching of muscles but no actual limb movement, and 0 being complete paralysis of the muscle. Moving on, stroking, poking, shaking, hot refers to the various parts of the sensory exam. As we learned about in a previous video, different kinds of sensory information travel along different pathways, so we need to test each kind in order to determine where damage may have occurred. These tests will also need to be repeated across various areas of the body, just like the motor exam. For example, someone may have intact sensation in their upper extremities but not their lower extremities, so if you only tested this in one location, you would probably miss this finding. You can test light touch by gently pulling something soft against the skin, which is the stroking from the rhyme. In contrast, pain sensation, or the poking from the rhyme, can be tested by applying a sharp but not dangerous object like a toothpick lightly into the skin. You can also consider testing for discriminative touch by placing 2 pins close together on the skin and asking the patient when they can discern that there are 2 sensations rather than just one. Under normal circumstances, 2-point discrimination is much stronger in areas with many sensory nerves, like the lips or the tips of the finger, and less powerful in insensitive areas such as the back. Testing vibration, or the shaking from the rhyme, can be done by applying a vibrating prong against the patient's skin and asking them when they feel it stop vibrating. Make sure to test proprioception, which also travels in the dorsal column medial meniscus pathway, as well, by asking the patient to close their eyes and tell you if they are lifting their fingers or toes up or down, which you can think of as being like a slow motion version of shaking. Finally, you can test the temperature, or the hot from the rhyme, by applying both a warm and a cold object, like a heated blanket or a metal stethoscope respectively, against the skin to ensure that the patient can discriminate between the two temperatures. Testing coordination is referred to as touch my finger in this rhyme, for reasons that will be evident in just a moment. Since coordination and balance are largely reliant upon the cerebellum, these tests help to determine whether the cerebellum is functioning correctly. The most commonly used test is the finger-to-nose test, in which you ask the patient to alternate between touching their nose and touching your finger while you move your finger around. This requires a cerebellum to be able to integrate visual information about the position of your finger with proprioceptive information about the position of their finger.
Go from the tip of your nose, the tip of my finger, back and forth. Okay, now I'm going to go out further and move. Good. Other side. A little bit further. And move back and forth. Very good.
Two other ways to test cerebellar function are the heel-to-shin test, in which you ask the patient to place the back of their ankle against the knee of their other leg, then run their ankle down the shin to the foot and back up again, as well as the rapid alternating movements test, in which you ask them to perform an action like moving their hands upside down and then back again, rapidly and repeatedly to test cerebellar function. An inability to perform any of these actions is suggestive of cerebellar dysfunction. There are several other ways of testing cerebellar function as well, but these three are a good place to start. The stand from the rhyme refers to the Romberg test, which is a very efficient exam maneuver as it quickly tests three different things: sight, balance, and proprioception. To perform the Romberg test, ask the patient to stand with their feet shoulder-width apart. Ordinarily, someone can do this without falling over by using three senses: their sense of sight, their sense of balance, and their sense of proprioception. Even if one of these senses is missing, the patient can still use the other two to compensate and maintain their balance. However, to finish the Romberg test, the patient must close their eyes. By doing this, you're taking one of the elements, sight, out of the equation. If they fall over after closing their eyes, however, you know that at least one of these functions is absent. The final step of the neuro exam is to test the patient's gait, or their ability to walk. Someone with a normal gait should be able to walk steadily without tripping or falling. They should even be able to walk when given specific instructions, such as walking only on their heels or the tips of their toes, or walking in a straight line, putting their heel in front of their toes, a maneuver known as tandem walking. An unsteady or ataxic gait can be suggestive of either upper or lower motor neuron damage, cerebellar dysfunction, or various forms of sensory dysfunction. And that's it. Those are the major components of the neuro exam. That's not to say that there aren't other aspects of the exam, as almost every step along the way can have additional maneuvers added to examine the patient in more detail. However, as a starting point, the maneuvers we've covered should get you most of the way there. At the end of the day, the best way to learn the neuro exam is just to do it. Find someone else who's trying to learn as well, then practice with each other until it feels comfortable. Rather than always having to refer back to a textbook, you can use this rhyming mnemonic to remind yourself of what steps come next. Good luck! Get some practice in so you'll be ready to see patients. Thanks for watching. I hope this video was helpful. Thanks again to Drs. Larson and Stensas for allowing me to use their videos. See the description below for the link to their website. If you're interested in learning more, check out my books, which are available on Amazon. Until next time, bye.